Ganesh, you want to start with introduction?
I think it was muted. So I once again invite all of you for this second webinar of this eight webinar series on technician recovery and certification. So we are happy to have Mr. Srinivas from the RIEB iBank manager, and he has got a lot of awards and recognitions uh, because of his huge experience in iBanking. In fact, many of you would definitely be aware of him because many of you may have got trained under him also. So it's a good opportunity for all to make use of his expertise, and whatever little doubts you have, you should definitely ask him. In fact, one of his achievements is to have got the Mary Jean O'Neill International Fellowship Award, and he has gone twice to Site Life and has undergone training in quality assurance in iBanking, the pre-cut tissue project, and also advanced training in iBanking. In fact, he has participated in many of the national seminars. As you are all aware, he's a trainer for the thing, and in fact now taking the role of training the trainer. So I welcome Srinivas to start with his presentation today. Srinivas, you can start.
Thank you, Ganesh. Thanks for the introduction. So good afternoon, everyone. So today we are going through the in situ donor corneal scleral rim excision using standard recovery procedures. So before getting into it, so I hope everyone attended the class on eye anatomy and physiology last week and understood well. Okay. So because this is very important to know the parts of the eye and functions of its each part, and this learning will definitely help us in understanding the recovery procedure. So in today's session, I am going to demonstrate donor corneal scleral rim excision at donor site. So the aim is to harvest safe and quality donor cornea by applying standard operating aseptic and surgical procedures without compromising the quality. So corneal recovery techniques, of course, will play a major role in successful corneal transplant. So technicians should have a consciousness during corneal recovery that the donor material will go to the patient suffering with corneal blindness. So make sure that not to transmit any diseases or infections to become a patient permanent blind. So as quality donor tissue largely contributes to the surgery success, it is important to implement all the procedures correctly. It calls for the adoption of aseptic measures, use of quality.
I request everyone else to please mute themselves. And GS also, please, if you can share the slides. Ganesh, is GS there? Or he logged out?
Hi, Raki. Maybe we should not wait for him. Maybe you can talk about this EDC this course, no? Why you started such an information you can share with them. Maybe they may understand what is really going on.
Thank you. Thanks, Sarvanan. Yeah. Ganesh, meanwhile, if you can check with GS where he is. So, um, hello everyone. I think there's a lot of questions coming in that what is a
मैम प्लीज मैं एक रिक्वेस्ट करना चाह रहा हूँ एक मिस्टर प्रकाश के नाम से एक व्यक्ति ने ज्वाइन किया हुआ है और वो बिजनेसमैन है और उसने अपने पीछे लेडीज अंडरगारमेंट्स की भी फोटो लगा रखी है प्लीज आप उसको हटाइए वहां से
Ganesh, if you can check that. कौन है ये?
ये प्रकाश नाम का एक व्यक्ति है सरदार है दाढ़ी रखी हुई है उसने और वो बिजनेस के मैंने उसके स्क्रीनशॉट लिए हैं इट लुक्स हैप्पी मैम
एक हटा दिया
थैंक यू
ठीक है
थैंक यू मैम थैंक यू सर थैंक यू
Yeah, so we were talking about the importance of the ERT certification program. So as you all are aware that last year iBank Association of India started the ERT certification where the assessment is done by the certified assessors at the conference. And once the person is assessed and if they are fit, then the EBI provide them with a certification which is valid for 5 years. So all these webinars are basically the precursor to the certification program, providing you all the information, all the training programs so that you can, once you have gained all the knowledge, all the theory part of it, then you can practically get your assessment done and then get the certification done. So that is the major purpose. It's also important that you all attend the webinars, all the webinars so that you have the complete knowledge about it. Please feel free to ask questions as well while you are attending the webinars. It's important to ask the questions to the experts, and you can also send your questions on the WhatsApp, even in the email as well. Is GS back now?
Yeah, yes, Raki.
Yes, yeah.
Are you
Okay,
able to
GS, yeah. Yes.
see the
Yeah, please,
slides?
yeah. Yes, please go back to the first slide and then start. Thank you.
Okay. Okay.
Yes, GS, please start.
So good afternoon, everyone. Today we are going through the in situ donor corneal scleral rim excision using standard recovery procedures. So before getting into it, so hope everyone attended the class on eye anatomy and physiology last week, taken by Dr. Niti Gupta, and understood well, because this is very important to know the parts of the eye and functions of each part. And this learning will definitely help us in understanding the recovery procedures. So in today's session, I am going to demonstrate donor corneal scleral rim excision at donor site. So the aim is to harvest safe and quality donor corneal scleral rim, applying standard aseptic and surgical procedures without compromising the quality. So corneal recovery techniques will play a major role in successful corneal transplantation. So technicians should have a consciousness during recovery that the donor material will go to the patient suffering with corneal blindness, not to make sure that not to transmit any diseases or infection to become a permanent blind. So as quality donor tissue largely contributes to the surgery's success, it is important to implement all the procedures correctly. So it calls for the adoption of aseptic measures, use of quality surgical instruments, and appropriate tissue harvesting techniques. So before starting the recovery, so we need to do the physical examination of the deceased and ocular examination, torchlight examination of the eye. Okay. So this will tell us something about the donor history, and also if there is any evidence of infectious diseases on the body that we will know. Okay, so for that we need to wear a disposable cap and mask. So we have to wear a pair of examination gloves, and so this is all we need to check. We need to look for skin bruises, needle track marks, skin rashes and lesions, lymphadenopathy, evidence of jaundice, oral thrush, surgical marks, tattoos, and bed sores. So why we need to check all these? See, there are two advantages. Like, sometimes in voluntary itineration calls, when we receive calls from home deaths, so the family members will not be able to tell any information about the medical condition of the patient, right? So in that case, this physical examination will definitely help us in identify the diseases with the donor, right? So by looking all these for example, if you find out any needle track marks, then you can go back to the family members and ask, so what happened to these needle tracks? So is there any infusion, transfusion happened to this patient? So if the patient is admitted to any hospital for any reason, right? So like that. And so evidence of jaundice, of course, when we need to check the eyes, the color and body color, and if there is any oral thrush, any infection in the mouth. So from that also we can identify something else, some diseases, if there is any oral thrush present in the mouth. And surgical marks, especially surgical marks will tell us a history of the patient, like if he has undergone any surgeries. So again, we can go back to the family members and ask, so what happened previously, whether he has undergone any surgery. For example, if you see any surgical mark near the chest, we can go back and check whether the patient is undergone any heart surgeries and all, right? See if there is any abdominal scars, any scars on the skull. So all these will tell us some story of the disease, right? So all this information is very important, crucial for the eye donation before approaching for recovery. So even of course bed sores. So usually, I mean, we commonly see patients home deaths. In patient home deaths, like patients, bedridden for several months, 3, 4 months, 6 months, like that. In that case, definitely we look to see for bed sores. If there is any bed sores developed backside of the body, okay. So that is also an indication for infection. If the bed sores are severe, then we'll not be able to consider the corneas can be suitable for transplantation, right? So all these information is very important. Need to take prior to go for recovery. So when it comes to eye assessment, so using torchlight, we have to check all these leads for inflammation, any contusion, any laceration. All these will be happen in road traffic accidents usually, right? So when any person met with an accident, usually the leads will be swelled and then contusions and lacerations in the body. So all these we can see. And conjunctiva, when it comes to conjunctiva, you have to see the inflammation, any discharge is from the lead margins, any bloodshot underlying the conjunctiva, and any icterus. Icterus means again the evidence of jaundice, that yellowish of the eyes, right? So that is the thing. And pterisium, if there is any pterisium growth on the cornea from the limbal side, that also we can identify, and any edematous of the conjunctiva. So that are all these needs to be noted in our eye assessment form. And again, epithelium. Epithelium is the outer surface of the cornea, right? So we need to look for any exposure. The exposure, when it will happen? So usually when the eyes are opened to the exposed to the air, then the eyes will get dried, right? So the corneal epithelial layers will get dried. So due to that, so that is called actually the exposure keratitis. So sloughing is after the stage of exposure, after severe exposure, then the epithelial layers start breaking. Okay, so start cracking. Then the epithelial layers will peel off from the cornea. So like how the paint is peel off from the wall. So similarly, the epithelial layers will get dried and then cracked and then slough off from the cornea. it peel off from the cornea. Okay, so that is called sloughing. Okay, so that we need to see how much is the exposure, percentage of the exposure, and how much is the epithelial layer is get damaged. So all these we need to note it down in the eye assessment form. So and then cloudiness and cornea for arcus, scar, infiltrates. Arcus, you know that people usually we see this arcus senalis in old age patients, right? So above 60 years, so usually all the patients will get some kind of white ring, so growth from the limbal side. So that is called arcus senalis. So that we need to measure and see how much the density is. Like it is a 0.5 mm or 1 mm or 1.5 mm from the limbus. So that is arcus senalis. And then scars, if we find any scars in the cornea, so that also need to be notified. And then infiltrates. Infiltrates usually, of course, we may not be able to find out with the torchlight examination, but still if the infiltrate is severe and significant, definitely we can identify with the torchlight. So the infiltrate is nothing but infection. Okay. So usually we see these infiltrates in ventilator dependent patients, right? Then comes to lens. So lens, the status of the lens, we need to check if there is any evidence of surgeries, any IOL scars present on the cornea, that we need to check. So lens status, usually all of us will have a natural lens, okay, God-given lens, right? So if the lens, the natural lens is not present and there is, in place of that, there is a glass IOL, intraocular lens is present, that is called pseudophakic. Okay, otherwise, if the natural lens, if you find, that is called phakic. And if you find any artificial lens, intraocular lens after cataract surgery is done, so they will implant intraocular lens. If that is present, then that is called as a pseudophakic condition. Okay, so then there is no lens, then that is called a phakic condition. Right. So all these findings needs to be noted in the eye assessment form. So prior to go for recovery, right? So the recovery procedures will have three major stages in the cornea recovery. So that is one thing is pre-recovery procedures and aseptic procedure and surgical procedure, right? So we'll start with the pre-recovery procedures first. So we need to identify the suitable work area to place the linen and other required materials. Okay, for that, so for example, if you go to any hospital or any house, so look for any empty table or an empty chair or an empty stool, or in the hospital if there is any patient trolley, usually they keep this medical charts and the trolleys. Okay, so we need to identify such kind of facilities and then so you can select it for keeping the materials. Okay, so for that, after identifying the place to keep your linen and other required materials, so we need to clean that area first. Okay, so for that, so we need to use some disinfectant like 70% alcohol. You can clean that area and keep the area ready for sale. Okay, so are you able to see the visual there? Sterile field preparation. So this is how we need to clean the field with alcohol wipes or cotton pads using the surgical spirit. Okay. So then we have to do the surgical scrub. Okay, before starting the aseptic procedure. So usually we always do dry scrub because we don't get any facilities to do the wet scrub. Like in a ward, operating room. Okay, so because we have to go wherever the body is, so there we will not expect any facilities for scrub our hands. So in that case, you can use this dry scrub method using 70% surgical spirit. So this is how we need to do our hand scrub. So we have to put the surgical spirit in one hand and we have to dip nails, fingernails into that, and then both the hands, then palm to palm, back of the palm, and then fingers interlaced, and the entire hand has to be get contacted with the surgical spirit until elbow. So we need to do the scrub until elbow. So once you've done the scrubbing until elbow, then again you have to repeat the scrub for only up to hands. because when you are reaching to the elbow, we are touching to the unsterile areas like shirts and any t-shirts all. Okay, so that is the reason we have to do it again. Finally, with only hands, like how it shows in the video. So then we have to prepare the work site. After clean that area, so where we have identified the area for keeping the linen pack and other required materials. So first we need to put on a sterile poly drape on the cleaned area. Then after that, so we have to pour. We have to throw all the linen, disposable linen or whatever the sterile linen on the field, and all the required gloves, surgical gloves, sterile gloves, and some cotton balls and sterile cotton balls and sterile mugs to take the powdery and saline. And there is a one sponge holder also you are seeing in the picture there. That are also required. So all these materials needs to be dropped on the sterile field prior to go for aseptic procedure. So this is all. So we have to set up the things in such a way that so all the body drape, head drape, eye towel should be keep a little away from these items: cotton balls, cotton buds, and sponge holder, and sterile bowls. Because all these right side material we use them for aseptic procedure, doing all the powder and iodine cleaning, and the left side the drapes we use after aseptic procedure we'll use these drapes to drape the body. Okay. Then wearing gown. So once we set up everything, then the technician who is doing recovery has to wear the sterile gown from the linen pack. Already we dropped that linen on the sterile field, and we have to wear the sterile gown and sterile gloves. So as shown in the video. So make sure that while you are wearing the sterile gown, your hands should be up position, and always the hand should be in above hip level. You should not fall back your hands below the hip line. So then the assistant will tie the tags. And after that, you have to wear the surgical gloves also. You can watch how the gloves needs to be wear. So using open gloving method, you have to wear both gloves. So then after wearing gown and then surgical gloves, we have to start with the cleaning of the donor facial skin. Okay. So first we have to clean the entire face of the, because why we need to do this step because once the death is happened, so all the bacterial multiplication will be so much in the body, right? So we need, so there will be a big load of bacterial this thing, infection will be there on the face or entire body. Okay, so we need to reduce the load of the bacteria. So for that, we need to do the cleaning with surgical spirit, cotton pad with surgical spirit, or if the alcohol pads are available, you can use the alcohol pads to clean the facial skin. Okay. So as shown in the video. So take an alcohol wipe and then first clean on the eye, over the eye first, and then you have to go to the peripheral area of the eye. Okay. So once you thoroughly clean over the eye, then you should not come back to the eye. Okay. So start from the eye and then go to the peripheral area, then clean up to the forehead and then below the cheek and on nose bridge also. So both side of the face we need to clean thoroughly. Okay. So if you want to use, you can use more wipes. So then after that, once you clean the facial skin with the surgical spirit using alcohol pads. So then you have to wash the eye also, because see, the bacteria will be there in the eye also, right? So we have to reduce the load of the bacteria even in the eye, right? So for that we need to clean we cannot use the surgical spirit inside the eye, right? Because it is a very toxic to the cornea. So we have to use the normal saline to clean the eye. So this is all we need to take the normal saline in a syringe, or with the 100 ml normal saline bottle is available, you can use that also straight away. So, and you can wash thoroughly the eye, lower conjunctival sac and upper conjunctival sac, and all the debris, all the dust and all the particles should go off, flush off from the eye, right? So the direction to do this, normal saline wash should be angling to the eye in a 45-degree, and flow should be start from the medial canthus. The drain should be go from the lateral canthus. In such a way, we have to do the cleaning. Like how see the video how he is doing. So we have to hold the bottle or a normal saline in a 45-degree angle and flush the eye, lower conjunctival sac and upper conjunctival sac thoroughly, and make sure that all the debris and particles flush off from the eye through the lateral canthus. Okay, similarly the other also we need to do. Then we have to change the gloves because the gloves what we have used are contaminated while we are doing this facial cleaning and then saline wash. So we have to change our gloves using another pair of sterile gloves. We have to start the aseptic procedure. Okay. So first we need to do the conjunctival preparation with povidone. So what is the percentage of povidone? So usually, commonly we all use 5% povidone in India. Okay, so we have to take a 5% povidone in a sterile bowl, and then take a sterile cotton tipped applicator and Johnson buds, and then dip it into povidone, and then we have to clean the conjunctiva from starting from the lateral canthus. We have to run through the lower conjunctival sac towards middle canthus. Okay, so I will show you the video. You can observe how the technician is performing the conjunctiva preparation. Simple. We just have to perpendicularly, vertically hold the cotton tipped applicator after dipping the PI, and then keep the cotton bud at lateral canthus, and then slowly we have to run through the lower conjunctival sac once towards the middle canthus. So similarly, again we have to come back and dip the another cotton tipped applicator, and then again start from the lateral canthus and go through the upper conjunctival sac towards medial canthus again. So that's it. So this is the conjunctival preparation. We just have to paint the conjunctiva with povidone. Simple. So then lid margin and lashes preparation with again the same povidone. Again you have to use another fresh cotton tipped applicator, dip it into 5% povidone, and come to the donor, and then start cleaning the lid margins. So you have to use another cotton tipped applicator to roll back the lid, and then use the cotton PA dipped cotton tipped applicator, and then start cleaning the lid margin and lashes once from medial canthus towards lateral canthus. Now it is the opposite direction. We have to start from the medial canthus. Now we have to keep the cotton tipped applicator horizontally. Okay. So we have to keep the cotton tipped applicator horizontally and start from the medial canthus, and we have to run towards the lateral canthus. Okay. So both the upper lid margin and lower lid margin we have to clean both. Similarly for the other eye. So in this, when you do this lid margin and lashes preparation, while you are rolling this cotton tipped applicator over the lid margin, no? So along with the lid margin, the lashes also will get contact with the povidone, because the lashes has a lot of bacteria. Okay, so that is the reason you have to keep the cotton bud, the cotton tipped applicator horizontally, so that all the lashes also can get contact with the powder, right? Then after that, after the lid margins and lashes preparation, we have to do the glove preparation. Okay. So in that glove preparation, again we have to take a sterile 10 ml syringe and grasp about 6 ml of powder from the bowl, and then come to the donor and then start dripping the powder onto the eye. Okay. So about 3 ml of powder we have to drop onto the eye. So first we have to drop about 1 ml of powder in a lower conjunctival sac, and then roll back the upper lid, and then again another 1 ml solution we have to drop off in the upper conjunctival sac. The remaining 1 ml we have to drop on the cornea. Okay. So entire globe should get contact with powder in such a way we have to drip the powder on the eye. Okay. Similarly, we have to do it for another eye. So for each eye, we have to use 3 ml, minimum 3 ml we have to use. So that is the reason we have to take 6 ml of powder in a syringe. Then after so once we drop off the powder in both the eyes, about 3 ml in each eye, then we have to leave the eye, close the lids and leave it for about 5 minutes. We have to leave it for about 5 minutes because the powder has to work on the eye, on the bacteria and fungi and virus, right? So we have to leave the eye for about 5 minutes, and meanwhile we can start doing the face preparation with the powder, right? So take a sponge holder from the sterile field and take one cotton ball and then dip in the 5% powder again, and first start from the over the eye. So start from the eye, the facial skin. We have to paint the facial skin with powder like how we see in the video. In 5 lines we have to do like. So this is first we have to do the face paint first over the eye. Then again we have to take another cotton ball and dip it in powder and again we have to do over the eyebrows, and then that is the second line. And the third line would be below the eye, over the cheek, and then again the fourth line will be over the forehead, and the fifth line will be below the cheek. So this is how we have to do the cleaning. You have to put 5 lines with 5 cotton balls for each eye. Okay. So likewise, we have to use 10 cotton balls for to make a 10 lines so that the entire face will cover with powder iodine. So literally, the powder iodine has to be flow, like how you are seen in the left picture, no? So that has to flow overflow on the skin. Okay, thick paint we have to do. Okay. So then once the, we have already poured the powder onto the eye in both eyes, right? So we have left it for about 5 minutes, right? Now we have to clean the eyes. Okay, after 5 minutes, we have to clean the eyes with again normal saline. Okay. So initially, before starting aseptic procedure we have done one time, and this is the final time. Okay, we have to do it again after aseptic procedure is done. So after 5 minutes, you have to use again another sterile 10 cc syringe and grasp about 10 ml of normal saline, and then come to the donor and start cleaning the eye with normal saline. Same way how we have done initially. First, we have to flush off the lower conjunctival sac and then upper conjunctival sac, then again over the cornea. So while you are, doing the eye wash, while you are doing the eye wash through the cornea, make sure that you are not giving any pressure applied to the syringe, because you should not, give any pressure because the epithelial layers will fall. Right. So you have to, medium pressure, you have to do that flushing. So once you're done with that, eye wash with saline, then you have to change your gloves because you have your gloves are already get contaminated during aseptic procedure. So you have to change another pair of gloves, wear another sterile pair of gloves before starting the surgical procedure. Okay. So before starting the surgical procedure, after wearing the sterile gloves, so we have to drape the entire body with sterile drapes. Okay, so we have already dropped the sterile drapes onto the sterile field, right? So we can use those drops to drape the entire body. Okay, so first is the full body cover, that big drape you have to put on the entire body up to the nose, and then the second drape will cover the head of the deceased, like how you can see in the video. Like second drape will be on the head, and then finally we have to put the eye towel. Okay. So after done the body draping, then we have to open the sterile supplies. So you all must be aware about how the sterile supplies should be opened, right? So all the VC peel packs should be hold at the corners and open up. And then if there is any sterile instrument set like this, so we have to open up from the other end. So where we have folded inside the cloth, no? So and make sure that before opening the sterile packs, you have to keep checking the sterile pack whether the packs are sterilized properly, and the indication, color indication, the sterility indicator, the color has changed, and the pack is within the expiry date. Okay, so these three things we need to check before taking the instrument kit for the recovery procedure. So this is how we need to check before starting the recording. So then after that, we have to set up the blades. We have to use two different number of blades. One is the 11 number blade and one is the 15 number blade, right? So 11 number blade, we use it to make an incision on the sclera, and 15 number blade we used to use for scraping the sclera, right? So we have to insert the speculum by using forceps. First, take a forceps from the tray and then roll back the lid first. We have to insert any antibiotic drops, clots, or gentamicin onto the cornea to keep the cornea moisture. Likewise. So just 2-3 drops are enough, not to not to fill the entire eye. Okay. Just to keep the cornea moisture. That's all. So then we have to start with the conjunctiva removal at limbal juncture with using one forceps and one conjunctival scissor. We have to take forceps and scissor from the tray, and then cut the conjunctiva at the limbal juncture. So you can watch the video clip of how it started. So exactly the scissor has to be in a 45-degree angle, and only you have to just cut the conjunctiva at the limbal juncture with only the just sharp tips. You should not insert entire scissor into the conjunctiva. You just have to cut the conjunctiva at limbus with just the tips, okay, scissor tips. Okay, make a small hole and then see, like watch the other video on right side and then just cut at the edge of the conjunctiva and close the scissor and insert the scissor inside the conjunctiva and make sure that the additions between the conjunctiva and the sclera is detached. Okay. So similarly, I have to go through the 360-degree and then cut the conjunctiva close to the limbus. Okay, and then separate the additions between the conjunctiva and sclera. So once you are done with the conjunctiva separation, then usually see even conjunctiva excision. So here are the common discrepancies again. Okay, so if you don't do the conjunctiva proper excision, and you can see the picture on the right side. Okay, so all the conjunctival pieces and it will float in the media in the cornea. Okay, and it is, I mean, see, conjunctiva is a major source of infection again. Okay, if you left out any conjunctival piece at the limbal juncture, so that will cause contamination in the media, and then ultimately the cornea will end up with infection. Right. So make sure that the conjunctiva is properly removed from the conjunctiva, I mean limbal junction, and it is away from the cornea. So then we have to do the scleral scraping. Okay, start with, I mean, using again the same forceps and using a 15 number blade. Keep your 15 number blade horizontally at the limbal juncture. Then you have to scrape the sclera downwards about 5 to 6 mm downwards. You have to scrape the sclera. Okay, so you can watch the video here. So start from the limbal junction and scrape towards downward. Okay. So once you are done the scraping downward, you should not come back to the same way again. Okay. Again, you have to start from the limbal junction only. Okay. So likewise, you have to do the scraping 360 degree, and it should be continuous actually. So you should not do any interrupted scrapings. Okay. Once if you start from the lower lid side, you have to continue towards again upper lid and then continue 360 and come back to the same position. Okay. So the scraping should be continuous, overlapping, and there should not be any interrupted scrapings. Okay, if you don't do the proper scraping, so you will leave up with some conjunctival pieces on the sclera, right? So those conjunctival pieces will come to, along with the cornea, will come to the MK media, and again the conjunctival pieces will get contaminated the entire media. So ultimately, cornea will get infection, right? So make sure that the scraping is done properly. Okay, 360 degree. You have to do the proper scraping and make sure that there is no conjunctival pieces, particles on the sclera, okay, before starting the corneal excision. So this is how we have to do the proper conjunctival scraping. See, there is no conjunctiva here. Very clean sclera. So once you are done with the conjunctival scraping, you have to keep all the instruments. I mean, whatever the instruments you have used for conjunctiva excision and scraping, the scraping blade you have and forceps, you have to keep those instruments out of the tray. Not, you should not mix the instruments with other sterile instruments. Okay. So throughout the procedure, all these three instruments should be kept out of the tray. Okay. So not to mix up with other instruments. So incision, we have to make a small incision for the corneal scleral rim excision using 11 number blade, using a 11 number blade and a fresh fixation forceps you have to take from the tray, and then make a small incision about 2 to 3 mm of incision parallel to the limbus. Okay, parallel to the limbus. Horizontally, we have to make a 2 to 3 mm of incision. Make sure that not to puncture the choroidal layer. Okay, so just have to cut only the sclera. Okay, not to puncture the choroid. Okay, if you do that, then all the vitreous will come out, and then the integrity of the glows will gone, and then eye will be collapsed. The cornea quality will be decreased. Okay.
वो एक ने कमेंट करिए उसमें क्या
So this is how we have to make a small incision with 11 number blade. About leaving
हमारी मेरी आवाज देखना
leaving the area about 2 to 3 mm from the limbus. Okay, this is very important. You have to leave about 2 to 3 mm from the limbus and then make a small incision. So not to enter into the posterior chamber. So then take it right corner, right or left, whatever convenient you have, then you can take right corner scissor and then start excising the cornea from the incision. So you can start from the corneal excision from where you have done the incision. So the scissor angling also should be parallel to the incision. Okay, so you should not, keep the scissor towards cornea. Okay, that the angling should be the way of the blades angle should be parallel to the incision. You can watch in the video. So see, so this is how we have to hold the scissor and go parallel to the incision, parallel to the limbus, not to direct these sharp edges towards cornea. Okay. So while excising the cornea, make sure that so while excising the cornea, make sure that you are entering into the only suprachoroidal space, not to puncture the choroid. Okay. See the right, there are three images I have given there. In the middle image, I have put a red dot there. So your scissor should be in the position of there only. You should not enter into the inside the eye. Okay. So that is the reason I always ask you people to keep the scissors upward and parallel to the incision. Okay. So you just have to grasp only the sclera and excise the cornea 360 degree. So once you are done with that, make sure that you can use a forceps and see again whether the entire 360 degrees properly cut or not. Okay. So make sure that the entire 360 degrees cut. And see, while when you are doing this corneal excision using the scissors, so make sure that the lid lashes are not coming inside the eye. Okay. So if the lashes are coming inside the eye, then you are end up with cutting the eyelashes also. Again, the lashes will come contact to the cornea, and along with the cornea, this cornea will go into the media. Okay, so make sure that not to cut the lashes, and if the lashes are objecting, make sure that your speculum is properly fixed. Okay, so not to come close to the cornea. Okay. So and then again the rim also. So minimum you have to maintain 2 to 3 mm from the limbus. So see in this picture, this is just a 1 mm, not even a 1 mm. In this case, we will not be able to use this kind of corneas for some special kind of surgery like DSEC and all. Okay. Because we need to have a minimum 2 to 3 mm of scleral rim to mount the cornea on the anterior chamber while preparing the DSEC lenticule, DSEC cornea. Okay. So we have to have a 2 to 3 mm of sclera. And even excessive rim is also a problem again. So excessive rim and irregular rim is also again another problem. So make sure that your corneal rim should be 2 to 3 mm only, not to exceed 4 to 5 mm. Okay. So see, this is the regular rim. Okay. So you have to restrict to the 2 to 3 mm and not less than 2 mm. If you keep taking excess corneal rim, then it will be a difficulty to transfer the cornea into the medium. So while transferring, you might get contact with the unsterile area, and then there might be a chance of introducing an infection inside the media. Okay. So make sure that just restrict to 2 to 3 mm of scleral rim. So here is the regular rim. So then come to the separation of iris, and then for that we have to use another forceps, iris forceps, and so you have to hold the scleral rim with one forceps, and you have to take another iris forceps to detach the iris from the cornea. Okay, so you have to hold the scleral rim with one forceps, and with another forceps you just have to a little bit of cornea, just have to lift it about 1 mm or 2 mm, and then slowly you have to bend yourself. Okay, so at this position, this is a very critical and crucial time to separate the cornea. because here you have to use your skills to separate the cornea with utmost care. Okay, so not to give any extra folds, not to give any stress lines on the endothelium. So you have to carefully separate the cornea. You have to have a patience here. You have to bend yourself and hold the cornea and lift the cornea a little bit, and slowly you have to insert the iris forceps and separate the iris from limbal junction. See, this is how we need to just lift the cornea at once, not to pull the cornea, not to give any pressure on the cornea. So that will create separate the eye slowly around the cornea. So while separating the iris, see, you can walk through the scleral rim using the forceps. So not to touch, make sure that your instruments are not touching to the cornea, especially not touching to the endothelium while separating the cornea. Okay. Make sure that throughout the procedure, you should not apply any pressure on the cornea. So that integrity should be that shape of the cornea. That integrity should be how to maintain throughout the procedure while separating the iris. Once you're done with that separation of the iris, slowly you can lift up with the cornea with the forceps. Then transfer into MK medium. Okay. So while you are carrying this cornea up to the vial, MK media vial, so you have to hold, you have to keep your second hand down below the cornea. So make sure that you are holding the cornea properly, vertically, because sometimes if the cornea is not holding properly, the cornea fell down. So at least the cornea will fell down on your another hand. So that again, you can pull it out and you can keep it in MK media. Okay. So if you don't keep your eye below the cornea, so the cornea might fall in somewhere else and it will get unscrewed, right? So use your second hand just to hold the cornea with one forceps, and the second hand just keep your second hand just below the cornea until you transfer it to the MK media. Okay. So you have to transfer the cornea aseptically into the MK medium. You have to hold the cornea vertically, actually, cannot horizontally, so that it goes into the MK media properly. Okay. See, like this, vertically you have to keep the cornea, then put it inside the vial until it reaches to the media. Then after that you can leave it. So the assistant who is assisting for the recovery, he will close the lid and he will mark it whether it is a OD or OS. Okay. So we'll go back to a couple of slides back and see. So if there is any excessive bleeding, so while you are doing corneal excision, there might be a chance of turbidity in the media. Okay, in that case, so that you will make out actually while excising the cornea, you will make out if there is any bleeding oozing out from the sclera. So you can use the sterile cotton tipped applicators and keep clean the blood from the sclera before transferring it into MK media. Okay. So otherwise, if you transfer the cornea into the MK media along with the blood, so the entire media will get turbid and will not be able to visualize the endothelium also properly. So all the RBCs will settle on the endothelium and it will absorb to the specular image also. Okay. So make sure that the blood is not transferring along with the cornea to the media. Okay. And while transferring, also make sure that avoid touching the margins, the edges of the vial with the cornea. Okay, so straight away, vertically we have to hold, and straight away we have to put it inside the media. Okay. So once you have done with that transferring of the cornea into the media, then you have to check the lens with the help of using lens cone, or you can use any blunt instrument, or even forceps also you can use, because you just have to palpate the area where the lens is. Okay. So just to rule out whether the lens status, whether it is a fakie or a pseudo-fakie or an fakie. Okay. So if you find out the lens is natural, so you can write it as a fakie. So usually even before the recovery also we do, but make sure that this is very important again. Even after corneal excision, we have to do it again because sometimes we may not able to see the lens clearly before excision. Okay. So now anyway it is totally open and you can clearly, visibly, physically see the lens status, right? So using forceps or any lens phone, just palpate the area and see whether it is a natural or artificial. Okay. So then we have to insert the conformer over the globe to give a live appearance to the donor eye. This is how using a transparent eye shell. After removing the speculum, then you have to place the lower edge into the lower conjunctival sac, and then using a forceps, and again upper edge should be going into the upper conjunctival sac, and place it over the globe and adjust it to make it center, and then close the lids properly. Okay, so lift up the lids and then close it properly so that it won't fall back again because it has a sharp edges to hold the lids properly. So this is how we have to give a live appearance to the donor. So once you are done with that, then placing the conformer, then again you have to clean the entire face because we have done a painting with povidone, right? So we have to clean the entire povidone marks on the face with alcohol pad and over the body to the donor family. And once after the cleaning of the face, then we have to draw the blood sample from the deceased, right? So for that, we have to take a 10 cc syringe and use a cotton pad using a surgical spray to clean the area where you are going to take the blood sample, whether it is a jugular vein or a subclavian vein or from a femoral. You have to clean the area first and then let it dry first. Okay, don't go immediately with the syringe. Let the area dry and then take the syringe and draw the blood sample, the required amount of blood sample. So this is how we see. We have to identify the jugular vein. This is a jugular vein actually. So identify the jugular vein, and parallel to the jugular vein, we have to insert the needle and collect the blood sample for about 5 ml. To minimum 2 to 5 ml, we have to collect the blood sample from the deceased. Now that all you know that we need to do the serological testing for HIV, hepatitis B, C, and syphilis, right? So transfer it into a vac container and place it in a flask. So discard all the waste in biohazard receptacles and pack the used instruments properly again back into the tray and store them properly for the lab cleaning. And that's all about the corneal recovery. And we are actually just a couple of days back, we have celebrated our Ramaiama International Eye Bank 35 years of service in providing sight to the corneal brand. So we have completed 35 years. We started in '89 and we completed in this year. Just wanted to inform you. And we have a small video for all of you to see about commemorating of this 35 years of Ramaiama International Eye Bank. I'm just going to play. With Commissioner Rati, can we play?
Yes, GS. You can play the video.
So if you have any questions, meanwhile, I can drop all your questions, queries, clarifications in the chat box. So we'll attend shortly.
Okay. Good afternoon, Mr. Srinivas. How are you?
Yeah, I'm good. How are you? Who is this?
I'm fine, thank you, thank you. It's nice to see you here. I just want to ask one thing. Here we are doing a whole globe excision, the inoculation.
Okay.
Because sometimes this donor this comes seropositive, then we have to discard that media if we take that rim. So is it okay or is it acceptable?
So it means you
We
take the whole globe,
waste
right?
the media.
I didn't get your question. I mean, you mean you'll first take the whole globe and then you'll extract the cornea in the lab?
No. First we are getting the whole globe.
Okay.
Then we get the blood tested. And
Okay.
if the blood test is negative, then we make the corneoscleral rim. If it is a seropositive or something else.
Okay. Yeah, that is fine actually, absolutely fine. If it comes negative, then you can do the processing.
We have to go further. Yes.
Yeah, you can go further. Yeah, that is best option to do instead of wasting MK media immediately.
Otherwise, if
you have time, you can do like that. Otherwise, sometimes what happens usually serology takes a lot of time, right? Sometimes the report come back to the bank, it might take a lot of time. So by the time we have only very less time to process the cornea. In that case, we cannot wait until the serology report is come back, right? So if you have time, you are getting the reports immediately, you can go with that. It's absolutely fine.
Okay, even one more thing. While we are getting the whole globe, so see, we are associated with an eye hospital. So if there is any patch graft required, then we can use that sclera also.
Yeah,
so
definitely. That is
very, very helpful.
That is good for actually. So we can also get the sclera, we can process that, we can use that.
Yes, sir. Yes, sir.
Yeah.
Okay, thank you.
We have a few questions in the text box. Maybe you may check and answer their questions.
You can also ask. Yes, Saronan.
Yes, meanwhile, you have to check the chat box. There are a lot of questions. Maybe you may answer it.
Okay.
If you want, GS, I can just read the questions from the chat box.
Yeah,
Like that's
I'm
easier.
just little busy with the opening of my video actually.
Okay. So there's one question from Simran that can we use a cornea from the HIV positive donor for a HIV positive patient?
First of all, actually, we don't take HIV positive cornea. Okay. So any technician, that is a high risk for the technicians who is recovering cornea, and that anyway absolute contraindication, we should not take the cornea. Okay. Even if it is a HIV patient, we should not take cornea, we should not use.
From a humble start of supporting 20 transplants to being India's largest eye bank, supporting 5,000 plus transplants every year, the Ramyamma International Eye Bank has had a monumental
Are you able to see the video?
Yes, GS.
Okay.
journey with several key milestones. It was inaugurated in 1989 with initial funding from the Gunnam Ramyamma family, technical support of International Federation of Eye and Tissue Banks, Baltimore, USA, and training support from Eyesight International, Canada. In 1990, we initiated the first ever Hospital Cornea Retrieval Program, HCRP, a successful model adopted across India now. We went on to establish 12 HCRP centers in the government medical college hospitals and district headquarters hospitals of Warangal, Mehboob Nagar, Kurnool, Karimnagar, Adilabad, Anantapur, Tirupati, Nellore, and Ongole in the states of Telangana and Andhra Pradesh. Year 1994 marked our contribution to the medical standards of eye banking in India, an initiative of the National Program for Control of Blindness under the Ministry of Health and Family Welfare by Government of India. We also began manufacturing the cornea preservation solution called Macquarie-Kaufman MK Medium. We did not stop there, but also started distributing MK Medium to our neighboring countries. In year 2000, we began providing amniotic membrane and scleral tissue for ocular surgeries. Year 2002 marked the establishment of community eye banking services. We established the first of its kind International Training and Resource Center for Eye Banking and Corneal Transplantation in 2003, which was made possible with the support from Eyesight International Canada and Orbis International USA. Year 2010 brought development of eye bank infrastructure in India. SightLife became our partner in realizing this dream. In 2012, we established the SightLife Advanced Tissue Processing Center, providing pre-cut tissues for DSEC surgeries. 2015 was the year we set a world record for supporting the most transplants from a single center, with 20,000 procedures in total. SightLife USA awarded Ramyamma International Eye Bank with several awards in 2017. Excellence in Eye Banking Award, 3000 Transplants Club Award, and Eye Banking Leader of the Year Award. Year 2018 meant the beginning of a new partnership with the Hans Foundation for capacity building to establish state-of-the-art eye banks in North and Northeast India. In 2022, we were honored with the Global Alliance of Eye Bank Associations inaugural National Award, recognizing LVPI's extensive eye bank network and our significant contributions towards combating corneal blindness in India. We also started developing pre-prepared corneal tissues utilized for DMEC, a partial thickness corneal transplant surgery. Today, the Ramyamma International Eye Bank is recognized as the leading eye bank in Southeast Asia and a center of excellence. As we celebrate this 35th anniversary, we are grateful to the families who choose to donate the corneas of their loved ones, HCRP hospitals, NGOs, volunteers, and eye donation centers in the states of Telangana and Andhra Pradesh, because of whom the hope of sight continues to shine and brings light into the lives of those who need it most.
Thank you all for watching.
Thanks,
Thank you so
GS.
much.
There are few questions, GS.
Okay.
What,
yeah.
but I know that we have already passed the time. So what I will do is that we will get the questions from the participants on WhatsApp and email, and then I
Okay.
will send you the questions, and maybe we can have a Q&A session after some time, because I think this was very, very useful for every one of us, and definitely more questions means that we need more clarifications as well in
Right.
future. So thank you, everyone. Ganesh, if you can give the vote of thanks.
Thanks, Srinivas, for that very elaborate and step-by-step explanation. In fact, some of the things that you said maybe overlooked, but only when you go through the process, you know how important it is for the to follow the aseptic and even the sterile conditions. So thank you very much for having given such a wonderful insight into the corneal session. So I thank you. I also thank the participants for having participated actively. Though we are not able to answer your questions, but we'll have to get back to you. Thank you very much.
Thank you.
Thanks a lot. Bye bye. Bye.
Thank you, guys. Thanks,
Okay.
everybody.
Okay, thank you. Bye.